Thanks so much, Renee, and I want to thank the organizers for inviting me. This looks like a fantastic meeting, and it's my first opportunity to be here. I want to talk today about getting personal. First, I want to provide a little bit of context for the concept of personalized or precision pain care. And I'll give you an example from a group at University of Florida, and then we'll talk a little bit more about what it's going to really take to get to precision pain care. And of course, I think you all talked a bit about the opioid epidemic. We know we're in a crisis here with opioids causing many societal harms. And of course, the response to the crisis is causing harms of its own. And when you step back, you wonder, why is there such a focus on opioids? We have a huge number of available pain treatments. Drug.com says there are 537 pain medications out there. And in addition to medications, as we've just heard about, we have a lot of other options for managing pain. And it seems like with all of these treatments available, we should be able to offer the patient in our office something that will be helpful for them. But what we still have difficulty doing is matching the treatment to the patient and being able to determine ahead of time which patients are likely to respond to which treatments. One hope had been, with the mapping of the human genome, that would answer all of our questions and we could use genetics to match patients to treatments. As you probably know, that hasn't turned out to be particularly easy. I'm going to give you an example of a genomic medicine approach that some colleagues at University of Florida have conducted. We have a personalized medicine program that goes well beyond pain, but we also ran a brief pain pilot study. And we have more ongoing, and this was based entirely on CYP2D6 genotype, which, as you know, metabolizes codeine. If you don't have a functioning CYP2D6 enzyme, of course, you can't metabolize codeine to morphine, and so there will be no effect whatsoever. But codeine is not the only target. CYP2D6 is also involved in making prodrugs out of tramadol, hydrocodone, and oxycodone. And you can look at different CYP2D6 phenotypes, if you will. That is, your genotype changes the function of the enzyme, but so do drug interactions. So from genotype, you can get people who are poor metabolizers, intermediate, ultra metabolizers, or normal metabolizers. And you see that the vast majority of people are normal metabolizers based on genotype. But then if you look at drug interactions, which cause phenoconversion, that is, they might turn a normal metabolizer into a poor metabolizer, for example, it can change the picture quite a bit. And so my colleagues in the personalized medicine program did a pragmatic trial in which they randomized clinics at the University of Florida to either conduct genotype-guided pain care, these were primary care clinics, versus a control set of clinics that just did usual care, didn't use genotype to guide the care. And the basic idea was that at baseline we collected data on the patients, we took genotype information, we provided feedback to the providers, and then we followed up 3 months later to see if the patients had done any differently. And in the control clinic, there was just pre-assessment and follow-up with no genotype information. And the basic recommendations are outlined here. When you classify people based on genotype and drug interactions into these 4 categories, 3 of the categories end up getting the same recommendations, but for different reasons. The strong recommendation is to avoid tramadol and codeine. A moderate recommendation is to avoid hydrocodone and oxycodone. And there's simply a note to the provider that gives them these recommendations. It's up to the provider what they do with that information. So this is the general approach that we took. Here are some baseline characteristics of our sample. Again, a primary care sample because of the clinics that were randomized, they see different patient populations, and we ended up with some baseline differences in our groups. For example, race differed across implementation and control groups. Some of the pain diagnoses and medications differed. We did control for these differences when we did our analysis. And here's how our groups broke down in terms of their CYP2D6 phenotype. Based on genotype alone, about 86% of people were normal metabolizers. But when you then take into account drug interactions, only 63% were normal metabolizers, and the rest would have gotten some kind of a recommendation. So you can see that the drug interactions actually phenoconverted 22% of our patients to either an intermediate or a poor metabolizer. And here are some of the outcomes from that study. So these are intermediate and poor metabolizers, so they would have had a recommendation to avoid the specific drugs, tramadol and codeine. And what you see here is the change in pain from baseline to 3 months in the genotype-guided group in black and in the control group in gray. And what you see is that overall, and our primary outcome there is on the far right, the composite endpoint, which averages current pain, worst pain, and average pain. And what you see is that pain improved more in the patients who were in the genotype-guided group than in the control group, for those patients in whom there would have been a recommendation. And if you do another analysis, essentially a responder analysis, asking how many patients got at least a 30% improvement in pain, 23% of the genotype group had that improvement, whereas none of the control group were responders here. If you look at change in pain intensity in those patients who were treated with drugs where there would have been a recommendation to make a change, again, you see the genotype group did better than the control group. But with oxycodone, where there was also a recommendation, we saw no effect of condition. And whether this was unique to our study or whether that means that CYP2D6 involvement in oxycodone is less important, we don't know. And we also collected some other secondary outcome measures, physical function, which improved just a teensy bit in the genotype group and worsened in the control group, and then pain interference and sleep disturbance improved slightly more in the active than in the control group. And so what we conclude from this is, first of all, that we can actually do these kinds of pragmatic studies in real clinical practices. That was our primary question, actually. And there's at least a signal that this genotype-guided approach might improve pain control in patients in primary care. One of the challenges was, because of the genotyping technology we were using, when the provider was sitting with the patient at the visit where we had collected baseline data, the provider didn't have genotype information. So we got that information to the provider later, which means they had to make a change at some subsequent visit or in between visits, and that's obviously not optimal. So in the studies we're doing now, we're making sure genotype information is available at the time of the visit. When changes are made by providers, they're almost always, 90+% of the time, consistent with the recommendations according to the genotype information. But the recommendations were made about 30%, or the changes were made about 30% of the time, okay? And so we need to do something to improve the uptake of these recommendations. And obviously, as we've seen, considering drug interactions is critical, because that's where most of our intermediate and poor metabolizers came from. But this is a very simplistic approach, right? We're focusing on one gene and one gene only that metabolizes a handful of drugs that patients may or may not be on. And even if we stick with a genomic approach, there are many other targets that we might imagine. And when you think about precision medicine in a broader context, we need to take into account many more factors other than genotype, many of which are frankly much more important than genotype. So we need to broaden our perspective here. This is where the issue of individual differences comes in. I've been interested in this area for quite a while now. And I'll give you an example of individual differences in pain, okay? I do a lot of sensory testing, which is a euphemism for I enjoy hurting people in my laboratory, okay? I bring people in, and under controlled conditions, I apply painful stimuli, and they respond. And here is a group of 320 plus people on whom I have perpetrated a 48-degree heat stimulus. The average pain rating you can see there is 71.8. Each line there represents a person. Again, this is an identical, well-calibrated stimulus applied to every person in the lab. And here we have a handful of people who barely found this painful at all. And I've experienced this stimulus many times, and I find it, frankly, quite painful. And we have a somewhat less fortunate group of people at the other end of the distribution who found it maximally painful, and we have every possible rating in between for this carefully calibrated identical stimulus. These are individual differences in pain, and they're even larger in the patients that you're seeing in your clinics because those are under less controlled circumstances. And the approach I have taken, and many of us in the field have taken, to trying to understand these individual differences is the biopsychosocial model of pain. That is, we know that the experience of pain is sculpted by complex and dynamic interactions among biological, psychological, and social factors. And if we're really going to understand our patient's pain experience and optimally treat that pain, we need to understand all of the different factors that are contributing to their pain. And I'll give you a few examples here. Gender and sex have been heavily studied in the pain literature, partly because there's an excess female prevalence of many of the most common pain conditions. And here you see females, for example, if you subtract the prevalence of back pain in males from the prevalence in females, 4% more females have back pain, 9% more females have migraine pain. So the burden of clinical pain is far greater in women than in men. That's been well documented. If we bring people into our laboratory, this is a study that we did, 300 plus healthy young adults. We delivered different types of experimental pain stimuli to them. And you can see, so the way these data are computed, the average pain score for the entire sample is 0. So if your pain sensitivity is average, you're at a 0. As the bars go up, that means you have higher pain threshold or higher pain tolerance, and you're less pain sensitive. As the bars go down, lower pain threshold and tolerance and more pain sensitive. And you can see that all the blue bars, which are males, go up, all the pink bars, which are females, go down. This is an incredibly consistent phenomenon across the entire literature. You can also see that some of the bars are big and some of the bars are small, meaning that the magnitude of the sex difference seems to vary across pain modality and pain measure, but we have a comparable pattern of findings in the experimental setting, that is in pain sensitivity, that we have in the clinical setting, that is in the prevalence of pain, that females appear to be more affected by pain than are males. So if we're going to personalize pain care, we might need to take the patient's sex into account. We've also been quite interested in how people from different ethnic groups might experience pain differently. Again, based on the clinical observations that at least in this country and in many developed countries, individuals from minority groups, when they have pain, they tend to have pain that's higher in severity, and they tend to have more disability, and perhaps not coincidentally, they tend to have less effective treatment of their pain. They tend to get undertreated. We've done studies of people from different ethnic groups in our laboratory. This is a study of patients with knee osteoarthritis. slightly more than half African Americans compared to non-Hispanic whites, and a similar graph to what you saw with sex differences. And here we see that in patients with knee osteoarthritis, African Americans were more pain sensitive than non-Hispanic whites, and it didn't matter where we were hurting them. Okay? They weren't just more pain sensitive on their affected knee, they were more pain sensitive on the arm or on the hand, and so this pain sensitivity aligns with their severity of clinical pain. Our African American sample had more severe osteoarthritis pain as well. So we've got sex that might be an important factor, and now we've got race, ethnicity might be an important factor when we're personalizing pain care. And obviously the population is aging. There's interest in how age might affect health, including pain. If you look at the prevalence of pain across the lifespan in both males and females, pain prevalence goes up with age, at least until the 60s. Depending on the study you look at, pain prevalence might plateau or even decline later in life. But in general, pain prevalence increases across the lifespan. And when we do things in the laboratory, these are data from my colleague Joe Riley at the University of Florida, so we can do techniques in the lab where we measure your pain inhibitory capacity. That is, how well do your pain control systems work? And we do this by testing the extent to which pain at one site on your body reduces pain applied to a different site of your body. It's called conditioned pain modulation. And here what we see is that young adults got robust pain modulation. They show healthy pain control. In middle age, we're starting to lose that pain control ability. And by the time individuals were older adults, that is an average age close to 70, pain inhibitory capacity had essentially disappeared, right? And whether this is why older adults tend to experience more pain, we don't know, but it certainly fits the pattern that we see in the epidemiological literature. So now we can add age to the mix of things we might need to consider in personalizing pain care. And of course, genetics. Genetics are of tremendous interest because it's an objective biomarker. Everything seems to have a genetic component. This is a twin study done several years ago, which showed, perhaps surprisingly, that our attitudes, our political attitudes, are substantially genetically determined. That is, my attitudes about property tax and capitalism are roughly 40% genetic, okay? And frankly, if you think about this can be helpful when you meet somebody who frankly has moronic political views. You might be a bit more patient with them, recognizing that they could have a genetic disorder. Like political attitudes, pain is highly heritable. Back pain is at least in the mid-30s in terms of its genetic contribution. Chronic widespread pain even higher. And experimental pain, the kinds of things I've been talking about, shows significant heritability as well. These twin studies that estimate heritability tell us there is a genetic component, but they don't tell us what genes are involved. We've been interested in this for a while. We, years ago now, studied the mu-opioid receptor gene. So this is the gene that encodes the receptor that mu-opioid agonists work at, but also the receptor at which our own endogenous opioids work, including beta endorphin. And we showed there's this common polymorphism of this gene. It's called A118G polymorphism. So most people have two A's at that location on the gene, but about 20–25% of the European population has a G, at least one G. Some people have two. When we looked at people based on this genotype, if you had at least one G allele instead of two A alleles, you were less sensitive to pressure pain on your trapezius muscle, masseter muscle, on your ulna. So this particular polymorphism seemed to be somewhat protective against pressure pain sensitivity. The most studied gene in the pain space is the catecholomethyltransferase gene, which encodes an enzyme that metabolizes catecholamines. A group at North Carolina years ago now identified 3 genetic profiles of this gene, a low pain sensitivity, an average pain sensitivity, and a high pain sensitivity genotype. They showed that these genotypes were related to experimental pain sensitivity. And they also showed that the genotypes, the high pain sensitive and average pain sensitive genotypes, over a multi-year follow-up period, were more than twice as likely to develop painful temporomandibular disorder than their low pain sensitive counterparts. So not only was this gene related to experimental pain sensitivity, it was related to risk of developing clinically relevant pain. And I'll come back to COMT in a minute. As Renee mentioned, I am a psychologist by training. I am a recovering psychologist, though. I do mostly research now, not clinical work. But I do want to at least mention some psychological factors that might be related to pain. So for the last 12 plus years, I've been involved in the OPERA study, which was a study of more than 3,000 people who, at the initiation of the study, when we first met them, we knew they did not have TMJ pain. We selected them not to have TMJ pain, and we followed them for years, morbidly hoping that some of them would develop TMJ pain, because that was the outcome we were interested in. And we measured a lot of things. I'm just showing you the psychological data here. And what you're seeing here is the hazard ratio that indicates the risk that somebody with this, with a high level of somatic symptoms, for example, at baseline, would go on to develop TMJ pain in the future. Okay, so these are psychological measures obtained months to years before their TMJ pain started, and we see 2 broad categories of psychological factors were significant predictors of future development of pain, including global psychological symptoms and stress and negative affect. Now, I mentioned the biopsychosocial model earlier. I've highlighted the arrows connecting the different domains because one of the critical tenets of the biopsychosocial model is that these factors interact, and I want to give you some examples of that. I told you about the A118G allele earlier with pressure pain. Here it's looking at heat pain, and we see no genotype effect here. In fact, the G allele was associated with slightly higher pain ratings, so even higher pain sensitivity instead of lower, but there's no significant genotype effect. However, there's a sex by genotype interaction in that the G allele was protective against heat pain in males, but it was associated with higher heat pain sensitivity in females. So if we're going to do genotype guided therapy with this gene, we better take sex into account or we're going to be wrong half the time. I thought this was a fluke until several years later, this Norwegian group studied the same genotype in patients who had had lumbar disc herniation and sciatica. They followed them for a year. Whatever treatment they got is what they got. And they showed findings that looked alarmingly like what we showed, in that the G allele was protective against pain 1 year after lumbar disc herniation in males, but it was associated with higher pain levels in females. We've also been interested in how genes and psychological factors might interact. These are data from my colleague Steve George, where he induced shoulder pain with delayed onset muscle soreness. And if you have a high level of pain catastrophizing, which is a psychological risk factor for pain, and you have the COMT genotype that puts you at risk for pain, you had much more pain after this delayed onset muscle soreness intervention. Whereas if you had either one of those risk factors or none of the risk factors, your pain was lower. So here we have genes and psychological factors interacting, and we saw the same thing in a postoperative shoulder pain cohort. That is, the combination of high catastrophizing and a high pain sensitive genotype put people at substantially greater risk for high levels of pain. And another gene by psychology interaction comes from our OPERA study. And I told you we recruited a large number of people and followed them over time, and we collected information from them every 3 months. And so here you see at the baseline visit, in black are the people who went on to develop TMD. At baseline, nobody had TMD, but the group in black went on to develop TMD at some point in the future, and the controls remained TMD free throughout the study. And what we see is that as stress increased, that increased risk of developing TMD. So not only was baseline stress a predictor, but increasing stress was an independent predictor of development of clinical pain. But this was only true in people who had a COMT genotype that rendered them less able to metabolize catecholamines, which of course are stress hormones. So we have gene by sex interactions, we have gene by psychology interactions, and so we're seeing how complex personalizing pain care is going to get. A single gene certainly won't do it. And so I do think that personalized pain treatment holds tremendous promise. We've shown proof of concept of a very focused approach in one study, but as we've seen from the literature, we're going to need to take into account many more biopsychosocial factors if we're going to do a better job of providing personalized pain care. And I certainly want to acknowledge the many colleagues I've worked with and the funding agencies who supported our research. And I want to thank you for your attention.